So excited to be here today again with Jody. Happy Sunday. I hope everybody's having a great, like I said, I'm really excited to have Jody. Here she is. Hooray.
Hello.
Did it. Here we are. So thank you everybody for joining us. I see everybody kind of coming on to the call. Jody and I were chatting after our last Instagram live that we didn't really have a chance to answer a lot of questions because we were chatting so much and we had so many things to share and get on to. So Jody suggested that we do a question and answer period specifically. So we had a bunch of followers email in some questions, DM some questions, and of course we'll take the questions here down below. If you are a follower and you do put a question, I'll jot them down and we'll get to them within the session. So Jody, why don't you just tell us a little bit about yourself again for the people who are new to us here.
Okay. So I am a physical therapist. I've been a physical therapist for 40 years and specializing in treatment of facial palsy over the last 18 years. And I have a clinic that I co-own in the Washington, D.C. area. And we also do telehealth, so we could reach out to more people. And this is not a profession to me. This is a passion. This has become like my drive to figure out what I can do better to help everybody who suffers from facial palsy. I can't just sit back and say, well, let's do the same thing, because I'm still not getting you guys where you want to be. So we're constantly looking for new innovations. And the patients I work with are just fabulous. They just give me so much knowledge and guide me, and that allows us to just keep striving for the best recovery possible. I do want to also say, though, Barbie, that the way I'm going to answer the questions are going to be general. This is not in any substitution for seeing a facial palsy therapist or your physician, or or getting medical attention for individual guidance.
Yeah, personal treatment. Now, I love the telehealth option. I really do feel that COVID boosted that. I mean, that was a silver lining of COVID. I think it made it more of a normal thing. Now, I got to see you over telehealth a few weeks ago. I've been working on my exercises, and like Jody's saying, each person, especially with the facial palsy, it's so complicated. There's so many little tiny things going on in there that there could be some general kind of things that Jody will suggest for people, but I definitely encourage you to try to see her partner at their clinic, whether it's virtually or in person, because for me, what the most important thing is that I feel when I talk to you, both on these videos and in our appointment, is that it's, I'm going to try to explain this, but it's a thing. It's real. It's sometimes when we go, with Bell's palsy to doctors, because they're not as educated, they're GPs, they have a very broad general knowledge, and they're human, is that you kind of feel like when you're with facial palsy or Bell's palsy that it almost doesn't exist. It's kind of like, okay, well, wait and see how it goes. You're on your own. And I don't feel that way, right, with you and your clinic and your passion. So that is something why I'm just so excited to have you here today. People can answer questions and feel seen and heard and understand that there are people out there doing something and trying, because like you said, it's such a puzzle. You are just so passionate about it, from a science point of view too, which is so cool, because there's new things that you're coming up with, like, you're not coming up with them, but using them for the facial palsy, like dry needling and things like that. And it's just fascinating, and the ultrasounds and things like that. So what I was kind of thinking is, we'll start the questions kind of based on when you first get Bell's palsy as to kind of it evolves, and maybe start that way. Like I said, if there's anybody on the lives that has questions, please just type them in the bottom. We'll get to them. I have questions that people have sent in, and then I'm sure that I'll have questions as we talk. So the first question, of course, we've had is, what to do when you first figure it out. Obviously, I think there's a lot of videos about that. And then why don't you tell us a little bit about your book? Because I think the book is the first thing to get.
Okay, so we do have a nonprofit foundation that we started with a generous gift from the Marriott Foundation. And so we were able to put together this book called Fix My Face that is written by a multidisciplinary team. So, you know, I have a chapter, our oculoplastic surgeon that we work with has a chapter, plastic surgeon ENT who specializes in pediatrics, an ENT facial plastic. So it works at looking at the whole picture, and the multidisciplinary team is so important. I think it's so vital, and that's what happens when you kind of get into these little pods where the ENT facial plastics, you know, they have two solutions. They have surgery or Botox. And there's so much more we learn from each other of different options that are widespread between Botox and surgery and other things that we can try to improve the situation. Doesn't mean we're going to stop that from eventually happening, but
Right.
utilize those for better outcomes. But what I would say, besides buying our book, which I would love you to do because I just think it does give you a lot of knowledge, is getting on the right medication.
Mm-hmm.
Right? That's number one. So when I speak to patients for the first time and it's acute and it just happened, I ask them to see their physician. Now, a lot of times physicians are like you said, Barbie, like, oh, it'll just get better. Don't worry about it, you know, and they'll throw you on maybe a week of steroids and a week of antivirals, and that's about it. And what our research has shown is that there are three medication regimens that should be considered. One is definitely steroids, but steroids for at least 2 to 3 weeks. And the reason being is let's discuss the pathology of facial palsy, because I think that would help understand better why we go through this process. The facial nerve comes from the brain stem, so it's considered a cranial nerve,
Mm-hmm.
right? It goes through this long bony canal. The tightness, when everything is perfect, is pretty tight the way it goes through there. What happens is if you get inflammation to that, the nerve cannot send the signal to the muscle or communicate through this neurotransmitter. So there's a lot of inflammation that is preventing the message from the nerve getting to the muscle. So right. Steroids help reduce that inflammation. And research has shown really that the 1 week, and especially a 1 week tapering dose that a lot of physicians put you on, or a week to 10 days of a tapering dose, meaning you start at 6 pills and you work your way down, is not effective. So at least 2 to 3 weeks of steroids, unless there's some other complication going on, such as diabetes would be one indication. The second thing is antivirals. So when patients present with facial palsy, unfortunately, everybody just puts them in the category of Bell's palsy. And as far as the diagnosis of Bell's palsy, it's basically the diagnosis that is given when they don't know what has caused the facial nerve palsy. What we have found in our research is there is the virus, the Zoster Sine Herpete virus, that either presents itself with absolute shingles to the facial nerves. So you'll see vesicles erupt in your ears, in your mouth, and on your tongue, and that's pretty clear cut. That is shingles to the facial nerve, and that is called Ramsay-Hunt. I say it's clear cut because we know that. I cannot tell you, and I hear these stories from many of you, that you'll go to the doctor and you have to tell the doctor, this, I think this is Ramsay-Hunt. Right. I don't think this is Bell's palsy. The Zoster Sine Herpete is basically Ramsay-Hunt without the eruption. So it's kind of like getting chicken pox without getting the marks that
Yeah,
you
the bumps. Yeah, yeah.
right, the bumps. So in those cases, especially putting you on a long-term antiviral to fight this terrible virus is indicated. And that's at least a 3-month regimen, again, unless there's a medical reason not to have it. And so initially, you don't know when you're presenting. I mean, it's pretty crystal clear if you have Ramsay Hunt, but it's hard to know, is this going to be Bell's palsy, in which you're going to get better in 8 to 10 weeks? Or is this going to be Zoster Sine Herpete, which is going to take a longer recovery because the virus has really attacked the nerve? So we believe everybody should get this regimen, no matter what their diagnosis is. And then the third medication that is very important, and a lot of doctors are uncomfortable with prescribing because they don't know enough about it, is called Nimodipine. Nimodipine. And Nimodipine is a calcium channel blocker. And what it has been found with these research studies is that nimodipine helps nerve regeneration. So I know a lot of you are doing the B complexes and so forth, and they can't hurt, but there's not great research showing that they help. Nimodipine, there's actually research that shows that it speeds up the recovery of the facial nerve regeneration. So
Okay,
that's
so
number one, medication. Okay. Yeah. Number two is eye care. Okay. Right. Taking care of that eye, because if something happens to your eye, that's actually a medical emergency, right? If you scratch your cornea, if you get ulcers on the eye, those are issues that need to be dealt with immediately. So good eye care is very important. And when I say good eye care, what does that mean? So it means using a preservative-free eye drop during the day, and to use it every 2 to 3 hours. Because when you have facial palsy, one of the big things that is lost, besides the inability to actually close the eye, is your blink reflex. The blink reflex is innervated by the facial nerve, and that takes a while for that to come back. And so the way you get tears in and out of the eye is through the blink reflex, because the muscle around the eye is like a sphincter, so it closes and opens, and that allows the tears to come in and out and lubricate your eye. So that's not working, so that's why we need the drops every 2 to 3 hours. Lubricant at night is also very important. The lubricant is a heavier covering for the eye, and the only reason I say I tend to tell patients to use it at night is because it makes your vision blurry. So that's hard to use during the day. Third is to cover the eye, and that does not mean taping the eye shut, as you're told a lot of times in the ER. When you tape your eyes shut, what happens is your eyelashes are very fragile to start with. With facial palsy, you'll see, some of you, that your eyelashes tend to lose their curl and thin out. When you're taping the eye shut, you cause more of that thinning out of the eyelashes. The eyelashes are not just there to make us look pretty. The eyelashes are there as another protective mechanism to kind of filter things from getting into the eye.
Right, so, dust and things, right?
Yeah. And exactly. So that's why we recommend not just tape the eye shut. We recommend something called a moisture chamber, which you can get on Amazon, or you can make your own moisture chamber. And to make your own moisture chamber, it's actually very simple. You would take Vaseline and put it, so first you put your lubricant in, and then you would take Vaseline and put it around the eyebrow and like around the orbit area here. And you gently close the eyelid down, and then you take a piece of cling wrap, saran wrap, whatever brand you want to use, and you put it over the eye. Now, some people get that to just stay on, and that's fine. But a lot of times I tell patients to put a sleep mask on top of it, and it'll hold it in place. you never want to use any cotton material straight on your eye, because again, those fibers can get into your eye, can irritate your cornea. So you never want to just put a sleep mask on. You want this covering. The other misnomer is that you have to get the eye closed at night.
Mm-hmm.
It's not that the eye needs to be closed, the eye needs to be protected. So if the eye is open a little bit and as long as it's protected and nothing can get in there, that is fine. That is great. And then the other recommendation I have in the beginning and throughout when your eye is bothering you is to use a warm, wet pad to the eye, because your oil glands that lubricate the eye are not producing the oil they need to coat the eye. So heat opens up those glands, so that helps as well.
And I feel the heat, like when I do it, I feel, because I've had it for 6 years and my appointments do, I'm still doing it. It just feels nice too. Like it just calms your face down, because I feel like that side of my face is just constantly working so hard and in various ways. It just finally is kind of like, oh. So I think that it helps your eye plus the muscles in the area. Now I have a couple questions that have come up while we're talking now. So for myself, for example, I don't have Bell's palsy, which is quite ironic. And since this is Bell's palsy talk, and I didn't have Ramsay-Hunt, so I just had the virus. Now, I didn't have the regime and the drugs, which gave me synkinesis, I'm sure, was the main cause. So when someone goes in at the beginning, what we're saying is it can't hurt, right? Like, say even because at the beginning you don't know whether you have Bell's palsy or Zoster or Ramsay-Hunt. So what we're saying is get the drug regime either way, right?
Yes.
Is kind of what we're saying.
So there is a study that took, like, I want to say over 1,000 patients and diagnosed them. And initially, everybody was diagnosed with Bell's palsy. Mm-hmm. And then they started filtering out the patients. And it really, about 25% of those patients did not have Bell's palsy. They had the Zoster Sine Herpete, or even showed the eruptions later after they had the facial droop and Ramsay-Hunt. So these medications, the one that's the hardest to use is the Nimodipine, because there is a regimen that you have to use of when you can take it based on eating, and it could drop your blood pressure. So that does have to be monitored. But yes, you need to push for the medications. And one of the doctors we work with very closely from Georgetown University, Michael Riley, has a great lecture that he gave to the facial plastic community. And so, Barbie, I'm going to see how I can get that video to you, that you can post it, because a lot of times when you'll all go to your physicians, they're going to be like, I'm not doing this. I don't.
They don't know. Yeah.
Right. So one, take the book, because it lays it out in the book. But I'm going to try to see if we can post that video for you too, because then take it and take it to your doctor, so that you can discuss it with them. Yeah, for sure. Because a doctor isn't going to just be like, oh, okay, cool, you found this on the internet. Like, let me just prescribe you whatever you want. Exactly. Right. And the only other thing I would say, so for somebody that's in Barbie's situation, and we're talking about 6 years later, even though technically, based on age, she's not old enough to get the Shingrix vaccine, we are recommending all of you, after a year, after things kind of calm down, to get the Shingrix vaccine. And the Shingrix, whoever doesn't know, that protects you against shingles or that same virus. And that's from getting it again, or will improve. Right. So yeah, because that would be great if I got it on the other side of my face. That'd be awesome. That'd be a great day. Yeah. Or get it again on the same side. Right. Right. Not that it's not a high percentage that it happens to, but it does happen in like 2% of the population. And I'm not trying to freak you guys out, but it's, it is a fact. So anything we can do to minimize problems down the line is important. So
100%. Yeah, absolutely. Okay. So then we had a question about, the calcium channel blocker isn't available in Canada, Pamela said. So is there a one that is available in Canada, or how do Canadians get around that?
So yeah, so I need to find out, because I do have a couple of patients who have gotten it, and I just have to find out how they wiggled around this.
Okay. Yeah. Okay. So we'll follow up on that later.
The only
Yeah.
another calcium channel blocker might work, but the studies were done specifically with nimodipine, and so that's one that I can recommend at this time based on research.
Gotcha. Yeah.
So
okay, so then your eye is protected. That chamber is at night. During the day, you're going to do the drops as much as possible. And getting out there. Now, cold. A lot of people have asked questions about cold. Now, does that make it worse? Does it just make it uncomfortable?
Yeah. My brain was going right there. So a couple of things. Yes, cold makes it worse, because what happens, especially wind and cold, that draft is coming in and that dries out the eye. So a couple of things, and this is true for your whole face, because a lot of you will notice that in the winter your face is tighter. It doesn't like it. So using scarves around your face work well. I've actually have patients, even if they're going to be outside, like going for a walk or something like that, using those warmers that you go when you go to like the football games or something like that, you know, those instant warmers, that they put that on their face and then put the scarf around it.
Well, that's smart. Yeah.
To warm it
I
up.
just have my kids play lacrosse outside. So when I watch, I have a hoodie and then a scarf. Yeah. Because I mean, it's like any muscle, you know, obviously it gets more tense when it's cold, but it is our face. So we want to take care of that. Okay.
Correct.
So,
wait, one other thing.
Yeah.
So, with the heat going on in your houses, using a humidifier will help, because the heat dries out the air and then dries out the eye.
Yeah.
Using a humidifier. And for those that are watching us that are in warmer climates but are not using their air conditioning and trying to use ceiling fans can also dry out the eye.
Right. Anything to dry out the eye, because like you're saying, of course, when you get Bell's palsy or Ramsay, of course, it's like, oh, my face. But the damage to the eye cannot be reversed, and we don't want to be blind, basically, is what we're getting at, right? So I think that a lot of the focus is, of course, your face, but the eye should be the number one priority at the beginning as well. Medication, then eye.
Initially, I highly recommend, like when you first develop facial palsy, get to your ophthalmologist, your optician, anybody you see for eye health, and let them check you out. And just make sure that the eye is in good health to start with. They will also most likely 99.9% tell you not to wear your contacts. So
yeah, I couldn't, there's no way I was getting a contact in there anyways. Yeah.
Correct. But just, you know, some people really try still. Do not wear your contacts initially. So that would be one other physician visit I'd like you to have. And then one that maybe some of you don't think about, and this doesn't have to be done in the first 4 weeks, but I would say in the first 3 months, you should get to your dentist. And some patients ask me about, well, I'm afraid to go to the dentist. Will they do damage? No. What we need to do is we need to make sure that your gums and teeth stay clean, because, you know, a lot of times you get that pooling of food because you back there. And so that accumulates and could cause problems. So you might have to actually go more frequently for your dental cleaning, but positively see your dentist.
Yeah. And I would assume too, what was my question? Does it affect the saliva glands themselves on the parallel size too? Or, yeah. And those are the things that you never really think of. Cause again, my face. Like I didn't think about going to an eye doctor. Right. Because all I'm worried about is my face. Right. So that's great.
Nerve does innervate the salivary glands. So some of you might notice that you have dryness of your mouth area, and then utilizing like there's Biotone. There are other products that are out there specifically for dry mouth. So that's something you should consider. And so it's not just to help with the dry mouth, but think about how much harder you have to work on swallowing and loosening up the food with your tongue when you don't have as much saliva.
Right. Yeah.
So then that causes the face to work harder. Everything we're trying to do is to let the face calm down in the beginning, let it start healing and not stressing it out. And
right.
not stressing it out physically and mentally.
And mentally, you know, of course, which is easier said than done. And that's the first thing we always say is, and I'm going to add to the first thing. So we have, just to recap, we have the medication, we have get information, we have checkout, dentist, eye doctor, is to sleep. We have so many people that come on to Bell's palsy and they're like, or I see them on other boards and it's like, how soon can I get back to work? How soon can I get back to exercise? Like, you have a virus, like regardless of whether, you know, it's your face and you're stressed out, of course, because what's my face going to look like you have a virus. Like if you were throwing up, you know, constantly for 5 days straight, you'd probably stay in bed. And I think so that's the number one thing that I say. Like, obviously there's stress about work and vacation time and money and all that, but rest is definitely, you know, the number one thing to help your body heal regardless of what you have. So that was kind of
rest. And then once you feel like you can, aerobic exercise actually is very good.
Okay.
So, you know, getting on a treadmill usually is what I recommend for side, just because we worry about what can happen to the eye. And I don't mean like, you know, a long, big run and workout, but even if you do like 5 to 10 minutes and maybe do it twice a day, because increasing your circulation just promotes healing in the body.
And mental,
right?
Like getting and doing something.
So I don't want people just to stay in bed, right? Rest doesn't mean staying in bed.
Right.
Rest just means that you're not running around doing 20 different things at once.
Right. Yeah. Just taking it easy and putting yourself first and things like that. Okay. Now, so synkinesis is the next thing. My question is synkinesis something that's like going to happen, or is it something that you can prevent? So I do know the medication. Okay. So that's step one, since I wrote my questions down. But if you're like, are you just basically doomed to get it or not to get it?
So that's an excellent question. And so what we have found, again, with the research, and we are pretty big on research. I'm not trying to throw out things.
No, love it. Yeah, that's why I love talking to you. Yeah.
Right. So according to our research, the longer it takes the eye to close, the higher the risk of synkinesis. So that's why, and the last time we had spoken, we had talked about things to help get the eye closed. Getting the eye closed will definitely minimize synkinesis. If you have a severe case of facial palsy, I never promise patients that they won't develop synkinesis. Now, there are different degrees of synkinesis, right?
Sure.
So there is the synkinesis when you'll feel the twitching, say at your eye and mouth. Those are the typical areas you'll feel the twitching. But unless I'm like this, I can't see the twitching. And that's our goal. That's truly, I cannot promise you I'm going to get rid of all your synkinesis. But the goal would be that it would be so minimal that only you would feel it and it wouldn't show. And that's why early intervention with the medication helps to promote healing, decreasing the inflammation. Early intervention to assist with the eye closure is important. So pathophysiology of synkinesis, there's still kind of a couple of different theories out there. And really, I think it's a combination of what's happening. One of it is there are the 5 main branches of the facial nerve, but they start back in that brain stem. And so the theory is when they start getting into their different branches, the virus causes them to interconnect in that area. and then that's what causes these abnormal connections in the face. And I buy some of that. But what I see happening is, because of the eye, the way muscles and nerves communicate is through this chemical response. The brain knows I have to close the eye. So the eye is calling for that chemical. And typically, just based on anatomy and distance, the nerves that recover quicker typically are the ones that come in here. So a lot of you will say, you know, what first came back is I noticed a little at the corner.
Yeah, I would wake up and I'm like, oh yay, my face is working again, but no.
Yeah. So that's usually, and then the other branch that people forget about is the branch that comes down to the platysma. And again, that has a short distance to recover. So these have come back. They have the neurotransmitter, and what they're trying to do is to help the eye get the neurotransmitter. So they make this connection between the mouth and the eye, or from the neck to the mid face,
right,
to try to deliver that neurotransmitter. So I wish I had a better answer for you about the synkinesis, saying 100% I can cure synkinesis.
Oh, yeah, no,
and
right.
Yeah, so if anybody tells you they can cure synkinesis, they can't. They're not. They're fibbing.
That's what my mom would say, fibbing. Now though, you and I talked in our appointment, and I really like, and this was new to me, that we can improve upon synkinesis by so the synkinesis technically is still there, but we're encouraging the other muscles to work, or the other muscles to kind of work harder. Can you explain that a little bit? Because that to me was like a super light bulb moment.
So, nerve pathways, if they are stimulated with usage. So, you know, if the eye needs that connection from the mouth, that connection will stay there. But as we strengthen the facial muscles through your neuromuscular re-education of trying to isolate each specific muscle to only do the job they're doing, that nerve pathway will be the only one that's firing. So the nerve pathway that has connected from the eye to the mouth is utilized less, and then it dies away. That pathway is not used, and then it is not connected. But I do want to say another thing that we have found with our diagnostic ultrasound. So you do have this nerve interconnection, but a lot of you present with also this thickness and tightness of tissue, right? And so I do want to address that. I'm sure there are some questions about that. So the tissue in the face specifically, we have skin, we have a fatty layer, we have the muscle, and around the muscles and around the rest of the organs in the body is something called fascia. Fascia is like when you take the skin off of a chicken breast and you see that white glistening stuff between the skin and the meat, that's fascia. Fascia stays nice and loose when there's activity, when there's normal activity. That's how it stays nice and loose. If you don't move it, it thickens up. So think about it as a web, almost like a spider web. And what happens is that web will tighten up. So it will connect. It's another way of connecting all of these areas. So that's why we ask you guys to massage and stretch and do everything to try to keep the tissue as loose, so you don't have this fibrosis or basically scarring of the area.
Yeah, that's how I kind of understand it, like scar tissue around.
Exactly.
Now Diane's here. Now she just asked a question. Now I think that it might be specific to this. So she gets from her front ear to her neck would have a rubber band snapping sensation for a time if someone made her laugh, which was painful. Now, is that tight fascia in there, or?
Well, it's a combination of tight fascia, but also platysma synkinesis. So a lot of you will have that with laughing. You'll get like a cramping sensation in your neck. I have patients describe it happening when they take a shower, because then they're pulling on this platysma.
Oh, right, yeah.
Doesn't want to pull, so it'll cramp up. So stretching and massage to it works very well. But I am a proponent about early Botox to the platysma. Okay, because the platysma, I call the it's really not, it doesn't serve a purpose. It's the it can be stopped immediately. And so I do not have the data yet on this. This is a research project we are now working on. But based on my ultrasound assessment, I am able to see when that platysma synkinesis starts. The minute I see it, when the patient goes into a smile or a pucker or a laugh, as soon as I see those fibers tightening up, I'm sending them to the doctor and getting platysma Botox. Because you don't want to Botox anything on your right side when you are recovering. Botox will stop that recovery. But in the platysma, we don't really care if it recovers, which is why when they go in and do that selective neurolysis surgery, they basically cut that platysma because it's really not useful. It more inhibits all the activity that goes up into the area. The platysma goes from, now can you see my collarbone?
Yeah.
Okay,
I'll
great.
do it too. Yeah, here.
Okay, so the platysma goes from actually below the collarbone. It's a very wide but thin muscle, and goes from there and actually inserts up into the mid face, and its fascial fibers blend into this whole area there. And so the platysma just wreaks havoc on the area. So if you can convince, if you're having that cramping, or you feel that band or that rubber band, or you see these bands under here, Botox, Botox, Botox to the platysma.
And just for people who are watching now, obviously ideal to get down to Jody because she can do ultrasound, but in my virtual appointment, Jody also has ways, like we did certain things and you can visually see what's going on here. She sent me paperwork. I can have her recommendation and go to somebody for both Botox up here. So for people watching and people joining in later, I don't want people to feel like, oh God, well, I don't even live close to there, so I can't do anything, which is what I felt when I first got, because there was a couple centers or clinics back 6 or 7 years ago when I was looking. I'm like, well, that's expensive, I'm not going to get down there. So because of telehealth, everybody is able to do this. So that is, yes, with the Botox, some people have told me they've gotten Botox, but it hasn't been enough. Now, Pamela, who came down to see you recently, her and I have been chatting now. She said, yeah, it's quite a bit. It's a lot more than you would get for, I don't know, crow's feet or something, right?
Exactly. You're going for a good 25 to 30 units, because they're going to sprinkle, if they do it right, they need to sprinkle it around all of these areas, right? They
right.
Just
all in the area. Because it's a large muscle is what you're saying. It's not just like two little wrinkles that are right here. Now, just to give kind of a parameter, so you said 20 to 30 units, but what would be, how much would someone put in for like wrinkles on their forehead or something? How many units is that? 10?
With facial palsy or with?
No, just in general life, like people would know.
It really depends what cosmetic look they're
sure, but it's a little tiny bit.
But
is what we're saying.
Well, yeah, it's definitely less than 10.
Yeah, so little tiny. So what we're saying is 20 to 30 is quite a bit more, as if someone's doing something for just facial wrinkles or whatever.
And to put it in perspective, if we were going to have Botox, say, to your eye to help with the narrowing of the eye, we do maybe 3 units at the most,
right.
Yeah. So,
and then because this is such a big area. Now, a question that I've had too. So this is my Bell's palsy side, and people have asked. Now, my Bell's palsy side, I noticed my eye is more sunken in. Is that something that's very common with people? Is that because of paralysis, or is that just because my eye is different on that side?
Well, it's more that the tissue is retracted. And kind of pulls. So the eye is not really sunken in. It's if we loosened up all the tissue in the area, the eye would pop. It would look like your other side. So
the tissue is kind of like holding it down more.
Yeah, it's holding it down and it's holding it in.
Okay, that makes sense. Yeah.
Yeah. So that's why it looks like it's kind of sunken in. But that's where the stretching of
that you gave me and stuff. Yeah. Okay, so yeah, because we did a lot of stretching of the eyeball area. Okay, now synkinesis. Had a question, things to make sure it doesn't happen, but I think we covered that. We had lots of exercises and get the medication if you can. How long is too late to take the medication? So say you're, it happened 6 months ago and now you're sitting here watching this. Is that too late to start getting medication? Like, at what point is it kind of like, Kate, missed the boat on the medication?
So that's an excellent question. It depends. It depends on the lack of recovery. So if you're still kind of looking drooped, our doctors would put you on the regimen.
Okay.
If you've had pretty good recovery and you have muscle activity, then the nimodipine would not be something that we would be putting you on. Having an MRI, if you didn't have it initially, with most of you, you have not. You probably had a CT scan just to make sure you didn't have a stroke, but they didn't image the facial nerve. Having an MRI to image the facial nerve at that 6-month period is very beneficial to see if there's inflammation still going on of the nerve. Our thought process is, if the MRI still shows swelling of that facial nerve, then yes, steroids would still be a suggestion. As far as the antivirals, blood work can be done to check your viral titers, but our doctors kind of feel like still put you on them. It's really kind of very low risk, and to put them on, especially if you're having like any symptoms. And when I talk about symptoms, I mean, 1, the facial weakness, but 2, if you're having like discomfort in the face, any hypersensitivity of the face, if you notice that you're having tinnitus or ringing in your ear, if you notice that when you stand on one leg with your eyes closed, your balance is still off, those would be indications of getting back on antivirals.
Okay, good to know. And like you said, can't really hurt. So basically I would just take away from that, and correct me if I'm wrong, that even after, say, 12 months, maybe you could be still having those symptoms. Well, hopefully you're not, but at what point?
And that's why you need an assessment. You must have somebody who knows what they're looking for to address all these other things that happen besides the facial nerve. Because of where the facial nerve is located on the brainstem, that virus a lot of times also attacks your trigeminal nerve, which is cranial nerve number 5, and then cranial nerve number 8, which is your vestibulocochlear nerve, and that's the one that would give you tinnitus or maybe even loss or balance. And I can't tell you how many patients will come in, or I'll do a telehealth and I'll say, do you have any problems with balance? And they're like, no. And then I have you stand up. And the test that you can all do on your own, but be safe when you do it, is stand on one leg, eyes open for 30 seconds, switch to the other leg, 30 seconds, eyes open, check how your balance is. Then what you're going to do is you're going to close your eyes and repeat that. If you lose your balance and can't stand there for at least 10 seconds, your vestibular system is still problematic.
Okay.
And if that's the case, I do highly recommend vestibular therapy, which is by a physical therapist, and they can assess you and improve that.
And that's funny, I've had that, but that because I had a bad concussion. And so very common, works very well, and way more common to find in your area is vestibular therapy.
Correct.
Now we have 2 questions here from followers. Now, Nina and Vero, both of you have said you don't have doctors in your area. Telehealth. So Jody is available, and her, you might not be able to get in right away, but get in on the list to make sure you can see telehealth. And let's not forget about that. That is something that we were saying earlier that has been quite a silver lining with COVID, is that this telehealth has taken over. So if you do find somebody on the internet that you're like, wow, this person is really, good in anything, vestibular therapy, all those things, just because they can't get their hands on you in a session anymore, you can still have, 80% of that recovery. So I definitely recommend that.
Right. And then the thing is, like, and I'm not saying you necessarily have to connect with me, but because our doctors are so passionate as well and so knowledgeable, a lot of times we can introduce them to your primary care,
Mhm.
and maybe they could guide your primary care through the proper protocol. So that's
Exactly. Yeah.
another option.
Because we had, yeah, so you know, you and I, we've only had one session so far, but those, so a person were to come to you, they could take them to their regular physical therapist and teach their regular physical therapist. I also saw a fascial stretch therapist for a while. You and I then talked about how it would be beneficial for fascial. It really did help. And I actually was one of the first patients that was coming to him because of Bell's palsy. So he did research and did that. So, you know, people with Bell's palsy, we can introduce those things to general practitioners who haven't maybe had those people come through their office or had the time to kind of look into it. So that is something that we can do, as well. Now moving on to, yeah.
A little thing in, we are trying to expand our clinics so that we are able to touch more people. I am very, very, very willing to train physical therapists who are interested in this and kind of open up like little satellite clinics. So I would train them, and this way I can be sure that you as a patient are getting proper treatment. But we are like, I have my license at least all around the United States. I don't have Canada, so we'd have to figure out how that would work. But I would be glad to help guide a physical therapist. But ideally, I'd love to set up all of these satellite clinics so that people have easier access, and then coordinate with the doctors in the area and so forth. Because I feel, again, very passionate about this, that I don't want everybody to feel like they have to come to the Washington, D.C. area. You know, if you live in the Midwest, I'd love to open up a clinic in the Midwest, teach a therapist how to do it there, and then be their mentor and work on that. So,
Okay, well, it sounds like you and me have a project to work on then, because I'd love to help out with that.
I
So we can get those rolling for sure.
I'm all in.
Yeah, no, I love it. I love your passion. Now, we talked about earlier, and we're almost running about an hour. So, which I know you and me could be here for hours and hours because we are both very passionate about it. Is surgery. So surgery, obviously, we want to look at it as a last resort. Now, those are the people who, when would surgery be something, you know, you're like, okay, hey, let's look at that.
So there are multiple surgeries we're talking about, right? And my thought, let's take the eye first as an area of surgery that is pretty common. I do not believe in the internal weights, the gold weights or the platinum weights, unless you have, and I don't think anybody's on this call that has it, unless you have like something like an acoustic neuroma, in which we know the nerve was cut and that muscle's not going to come back. So I don't think the problem with those weights is that you have to cut the eyelid to put it in, and then cut it to take it out, and they become heavy because your eye starts recovering. So that's why that surgery, an implant of the weight, I don't recommend. There is procedures that are done, and I call them procedures because that's truly what they are, in which you can use eyelid filler in that top eyelid, which helps bring,
yeah, I was reading about that, just weights it a little bit, like
it down a little bit. The filler lasts about 9 months. If the filler is too much, they can go in and reduce the of it very easily, and then putting 2 little stitches in the corner of the eye, not shutting the eye closed, not doing the surgery to shut. The only time you would do the surgery to shut the eye closed is if you have severe dryness of the eye or ulcers of the eye. And that's why you don't want that to happen. But if you're having trouble with closing the eye, they put 2 stitches in there, and that just makes it a little easier for that top and lower lid to meet.
Yeah,
so
it's less
stress.
and that's temporary, obviously, I'm assuming.
Yeah, that could be taken out if the eye comes back. That could definitely be taken out. Sometimes it stays in, just to give you that tight eye closure, for multiple reasons. The other surgery is what's called, it's a two-step surgery. It's a cross nerve graft with a muscle transfer. And that would be for somebody who has a very, very, very severe case of typically Ramsay Hunt or Zoster Sine Herpete, in which you really get no activity back, specifically like the smile. And so what they'll do is they will go and they'll take a nerve from the leg, they connect it to the facial nerve on your uninvolved side, they bring it across, let it kind of lay there, and let it sprout and develop, and then they'll take a muscle or fascia from your leg and they'll connect it to your smile muscle. So then you'll get like spontaneous smiling. So when you smile on your uninvolved side, it sends the signal to the,
right,
on the other side.
Working together. Now that
Working
is
together.
fairly serious surgery, I'm assuming, right?
It is serious surgery, and you know, that's one of those things that you have to look at as an individual and figure out, is getting, in some patients, is this going to give me as much recovery as I want, or am I just going to get like 10% improvement, and will that make me happy?
Mm-hmm.
So it's a big decision you have to make with the surgeon. The other, so, but that you have a good 9 months to 12 months to decide on doing that. If you, again, have a full droop at like the 4 to 6 month period, sometimes they'll do what's called a 5-7, in which they'll hook your nerve that goes to your masseter or your chewing muscle to your facial nerve and give it support that way. The good thing is it does give it support. The bad thing is, to activate it, you have to bite down. So you have to bite down and then activate that smile. So it's not a spontaneous smile.
Right. It's a, yeah, okay. That makes sense.
Right.
Okay. So yeah, so those are some surgery kind of options. I think basically I have all the questions really that we had written down for now. So if, and I mean, so much information, such a great talk. If anybody who's following right now, we have quite a few followers on here. If you have any last kind of questions, make sure you shoot them down there. And I think that this kind of structure of the question and answer was really great, because it kind of gave us kind of an order. I think that you and I have so much passion, we could talk here for about 12 hours. Quite.
Yeah, probably.
Yeah, so I think that we have a lot. What I'm going to do is, of course, as usual, post the videos. I'm thinking too, what I'm going to do is like smaller clips, but make sure everybody here, make sure you rewatch this video, you ask us any questions down at the bottom. Like Jody said, she's very open and willing, and we have a lot of work to do in the Bell's palsy and Ramsay Hunt community, and of course I'm very willing to get out there. You and I had talked about that, so we got some work to do. Let's get it done.
So I will tell you what my dream, and you know, COVID will definitely kind of change it, but my dream is, you know, we do these multidisciplinary presentations for physicians out there, and that's good to do it. But I would love to have a multidisciplinary presentation for facial palsy sufferers. They do that for the Acoustic Neuroma Society. They have it specifically for patients, and they bring the professionals in to speak. And it's a conference. It's not just, you know, this is great, and I think this is great, but like you said, we can go on and on, because there's so many things that people need to know. But if we could bring a bunch of multidisciplinary experts in and make it a conference, that would be fabulous.
Okay, well, we'll do that. COVID, obviously, but we'll work on it. We start working on it now. We'll be ready to go when COVID's done.
Perfect.
I am an event planner, just so you know. That's what my profession is. So
well, that's
sounds
why
like
it.
Yeah, sounds like we've been brought together for more than one reason.
Yeah.
I do have one more question that Risa says at the bottom. Is paralysis on both sides common? I would assume no.
It is not common. It is.
Yeah. So if you are someone that has had paralysis on both sides.
So one thing is, if you've had paralysis on both sides, truly you should probably be on antivirals forever. Because that means that the virus is just hanging out in your body. Right. So again, they need to watch your kidney function when you're on antivirals, but consideration of antivirals forever, or at the least the Shingrix vaccine. And I did somebody that about that. The Shingrix vaccine is two vaccines. It's a two-shot process.
Two-shot process. Now, just I mean, I do like to stay away from the COVID vaccine question, period, on Bell's Palsy Talk, but is that something that you do need to wait? Like, I've had the COVID vaccine. Does it interact? No. So it's just like you can.
There's just came out a study, and this is a couple of studies. One shows that there is not a higher incident of patients developing facial palsy from the vaccine versus developing facial palsy from getting COVID. Okay, which you can.
Right. Okay. Right.
The second thing is, and this part to me is a little scary, and this is a new research that came out, is that if you get COVID and have a history of facial palsy, you have a higher likelihood of getting, like an 8-fold likelihood of getting facial palsy again.
Because your immune system as well is so low. I mean, I would assume straight up.
It triggers the virus again. So, okay. So that is against what a lot of people are thinking, that I don't want to get it because I don't want it to cause facial palsy.
Right. It's the same thing now. But also too, you know, I've had the COVID vaccine obviously within the last 6 months, but the shingles vaccine is okay to just get. I can go tomorrow and get it. It's not.
Yes. There's a timing that they want spaced out. I think it's like a month. Okay. Something like that, but you could check with your physician or pharmacist and they'll tell you what the timing is on that.
Yeah, because I'm definitely going to get that then, because like we said, don't want to have it done again. Okay, well, thank you so much to everybody for joining us. Jody and I are going to be in touch. We got a lot of stuff to work on, and we will be back, because I do think that was the best talk ever. So let's be in touch. Have a wonderful Christmas if I don't talk to you before.
You too.
And thank you everybody for joining us.
Okay, take care. Bye.
Bye.